This is Katie Bodine, and we're going to be talking about hyperparathyroidism today. Like I said, picture's worth 1,000 words. I say this many times, but this is from osmosis.org. If you need to take a deeper dive into your review, I highly recommend this as a resource. And this is a global overview of the function of our parathyroid cells. And in detail, just to recall, our parathyroid hormone, and it aids in regulating our calcium homeostasis. So parathyroid is really good at keeping our serum calcium between 8.5 and 10 milligrams per deciliter. It's kind of amazing. So, and that's our extracellular levels. Now, there's generally 4 glands around the thyroid, behind the thyroid. They can vary from person to person. Some people may have more, some may have less, and they can be in, they're not perfectly placed, okay? Basically, the cells, they can manufacture, store, and secrete parathyroid hormone. So what does parathyroid hormone do? It actually is the hormone that's secreted when the receptors sense that the serum calcium is low, and it goes out and it recruits calcium for the blood. So it does this by stimulating the renal reabsorption of calcium. It does this in the distal convoluted tubule, and it also at the same time will cause phosphate excretion. It also increases calcium absorption from the intestine by stimulating the formation of active vitamin D. It also goes out and mobilizes calcium and phosphorus from bone stores. Okay, so it will stimulate that osteoclastic activity. Excess PTH is cleared from our circulation via the liver, and then it's excreted through the kidney when all is working well. So if we have reduced or absent PTH action, we can end up having issues with hypocalcemia, hyperphosphatemia, and hypercalciuria, right? So instead of excreting it, the phosphate, we're excreting calcium. Now that we've reviewed the normal function of our parathyroid gland, we can understand that hyperparathyroidism means that we have excess parathyroid hormone being released, which will result in high serum calcium. There is a female predominance of the disease, usually 3-to-1 compared to males, and usually found in the postmenopausal state. It's not an uncommon disorder. It can be in the U.S. Found in 1 to 500 to 1,000 people. And we divide this into 3 types of disease. So in primary hyperparathyroidism, this is an intrinsic glandular problem. So our parathyroids have gone awry. There is something that's causing excessive release of PTH and lack of those cells in intrinsic feedback mechanism, so they're not sensing the excess calcium in the blood. So their feedback mechanism is hindered. Most of the time, and this is, again, up to 85% of the time, this is due to a single parathyroid adenoma. Okay, this is a benign tumor that either some sort of mutation occurs, or maybe they have a genetic predisposition from an inherited disease like multiple endocrine neoplasia, which is MEN. I think we've been hearing this term more with all the Ozempic commercials. And then the other more rare causes are hyperplasia, and this is where all of a sudden there's just sporadic growth of the glands, and again, other things can, inherited diseases can cause this to occur. And then rarely, there can be a parathyroid carcinoma, and these are pretty aggressive and very detrimental. In secondary hyperparathyroidism, the parathyroid gland is normal, as with most secondary disorders, right? So it's making excess parathyroid hormone in response to something else. And usually it's in response to chronic hypocalcemia from something else, right? Because those receptors are going, there's a little calcium in the blood, so it starts overproducing. Usually this happens in renal failure or people with chronic kidney disease. So our kidneys aren't filtering, and so the phosphate, it's not properly being transferred into the urine, or perhaps we aren't making enough calcitrol. So the high level of phosphate, because our kidneys aren't working, actually reduces the amount of free calcium ions in the blood binding with them, and so then the lack of calcitrol means that there is less calcium also absorbed by the intestine. So secondary hyperparathyroidism can also be caused by a lack of calcitrol, either by the lack of sunlight or poor intake or absorption of dietary vitamin D. So those are the most common causes. Now, tertiary hyperparathyroidism, this is a situation that's had secondary hyperparathyroidism for so long that the gland kind of goes on its solo mission and independently, autonomously just keeps secreting PTH regardless of the serum calcium. So the phosphate level in these people may be, they may vary when you're working them up, because if they've had a kidney transplant, they may have normal phosphorus. If their kidneys are still not functional, they may have high phosphate. So this can vary. Okay, so in terms of signs and symptoms, these are going to go exactly, they're very intuitive, what you would think of with this chronic hypercalcemia, okay? This is generally incidental on screening labs. 80% of these patients are asymptomatic until they are. There's rarely any sort of physical exam findings. You might want to think of an older post-menopausal woman who's thin with osteoporosis and complaining of generalized depressed mood, abdominal pain, weakness, etc., and dehydration most likely. It kind of gives you a picture, as opposed to somebody who's cushingoid with that classic cushingoid appearance, like other endocrine disorders. So again, our classic board question, or when we're learning this in school, we talk about bones, stones, abdominal groans, thrones, and psychiatric undertones. That probably sounds painfully familiar. So when we talk about bones, these are proximal weakness, atrophy, and bone pain from the osteoclastic bone turnover. And sometimes you'll see this classic appearance of the subperiosteal bone reabsorption and the phalanges and clavicles. It's called salt and pepper skull on a plain film of the skull, which I'm not sure why you'd order, but it's due to osteoclastic activity. In terms of stones, up to 20% of these people can present just with the calcium-based kidney stones. Also, gallstones can form. Abdominal groans refers to constipation, anorexia, nausea, vomiting. This can also be because of dehydration from their polyuria. So that's what thrones is for, polyuria. So they get a little bit dehydrated, and this is from impaired sodium and water reabsorption. You've got this calcium going out, so is sodium, and where sodium goes, water goes, okay? And then we have psychiatric overtones. So there might be some chronic symptoms like depressed mood or foggy memory, confusion, maybe even altered mental status, or just chronic fatigue, which it's concerning because how many older, women or postmenopausal women come in kind of complaining about these generalized symptoms. So this can be frequently missed early on. Less commonly, medications can cause this. Hydrochlorothiazide is one that is classic, and lithium is another medication which we've had enough lectures now that that causes a host of other problems, but it actually decreases the parathyroid response or the sensitivity to serum calcium rather than actually directly affecting the parathyroid itself. So our diagnosis of hyperparathyroidism is going to be based first and foremost on blood tests that we want to confirm that there are indeed high levels of calcium. So we want to use our MedCalc and do our calculation, adjust. I did a little screenshot of a MedCalc conversion here. If you want to know the actual equation, feel free. It's your serum calcium in milligrams per deciliter plus 0.08 times 4 minus the patient's albumin in grams per deciliter. So rather than go through all that work, I just use my med calculator. Or you can order an ionized calcium. Okay, that's your free calcium in the blood. It's a little more expensive, but it's confirmatory. Okay, but we have to correct for that serum albumin because that is what binds and our calcium in the blood. Okay, so we need to know what our free calcium level really is. So once that high calcium's true, it's confirmed, we then follow with an intact PTH level. Okay, so we want to confirm that level of hormone is high, and then recall if your parathyroid function is normal, you have high calcium in the blood, you should stop having PTH release. So if you have high calcium, you should have low. So when you draw the blood, you have high calcium and high PTH, you know that you've got primary hyperparathyroidism, right? So always think of our secondary suspicions. So draw your, I would just draw BMP, making sure we're looking out for renal insufficiency, BUN, creatinine, vitamin D levels, your urinary calcium levels, and phosphorus, okay? So when we interpret these tests, and here's another beautiful picture from osmosis that summarizes how to differentiate primary from secondary or tertiary. Again, we know we have high calcium, so we draw our PTH, that's high, and then we have a low phosphorus, that's primary. Secondary, HPT, we have high calcium, high PTH, and then high phos, because our kidneys are not excreting. This is probably due to chronic kidney disease. Now, if we have low phosphorus, we might have a vitamin D deficiency. Both of these may have a normal corrected calcium level, but our PTH should still be high, okay, depending on our kidney function. Now, our tertiary or PTH independent, we should have high PTH. It could also, if it's having a moment where it decides not to be working because it's gone on a solo mission, right? It could be undetectable or low. So and then the phos level may vary depending on the renal function. So what do we do now? These are going to be referred to your local friendly endocrine specialist, an endocrine surgeon, and there are surgeons, a very experienced surgeon may do no imaging at all. Okay, they've confirmed that this is primary hyperparathyroidism. It's probably an adenoma, and they're going to do surgical resection. Okay, but not always. Okay, so if we want to confirm or find out the underlying cause, we can do a high resolution CT with or without a CT-guided biopsy, because if they're going to do a resection, they can just go ahead and send that off to path. And you can do a contrast-enhanced four-dimensional CT. MRI can be done, high-resolution ultrasound. There's a number of various tests, but the Tech 99 scan, that's going to be our most sensitive and specific for a solitary adenoma. Okay, so again, may or may not be useful to repeat these post-operatively, but if you have somebody who continues to be hyperparathyroid post-operatively, they're probably going to need to go back and do some imaging before a repeat excision. Okay, let's talk about treatment. Like I said, if it's primary, our first line is going to be surgery. It's preferred, especially because 85% are adenomas. You excise that, and that is hopefully curative. Okay, and that's done for primary and tertiary hyperparathyroidism. Now, if conservative treatment is required because surgery is contraindicated, then we can use some calcium mimetics, and those are drugs that they basically imitate the action of calcium because they bind to those calcium sensing receptors on our parathyroid cells, and so then they inhibit that PTH secretion. These are FDA approved, but do note that there aren't really any long-term studies on if this helps to reduce all these constitutional symptoms or fractures or neuropsychological symptoms. Bisphosphonates, if those of you who have patients who are osteoporotic, you're familiar with this, alloidodronate, this helps to reduce our bone turnover and maintain bone density. But these are contraindicated in people with chronic kidney disease, so you cannot give them if the patient's GFR is under 35. So just keep it, as with all medications that we prescribe, right? We want to make sure we're not hurting our patients if they need to be renally dosed or if they're contraindicated, period. Loxapine can be used, and then of course, although and raloxifene, it works by it antagonizes the PTH-mediated bone resorption, and of course conservative management is not really preferred because of the risk of bone disease. So if it's a adenoma, they really want to take that out and just stop the disease in its tracks. Other conservative management that should be done in addition, the patient should be remaining active, staying hydrated. Immobilization leads to exacerbations of hypercalcemia, okay? They need to have a low calcium diet. Again, lots of fluids because they want to minimize, 20% of these people get kidney stones, and so we want to minimize those chances of nephrolithiasis. And of course, avoid drugs that raise serum calcium, and these are your thiazide diuretics. We want to continue to monitor the serum calcium in terms of maintenance therapy. Be monitoring that about every 6 months. Keep watching for bone density yearly. And then, of course, if you have recurrent hypercalcemia, send them back to their surgeon or rescan them, okay? You can still treat osteoporosis with bisphosphonates. And with secondary hyperparathyroidism, surgery is rarely needed because it's a secondary problem. And so treatment is going to be aimed at managing the reason for the underlying cause. So managing hyperphosphatemia with phosphate binders and chronic kidney failure can increase the levels of vitamin D. They can use supplements and calcitrol analogs. I think that does it for the day. Y'all have a good one.